Good evening, and welcome to Understanding COVID-19, a virtual town hall event hosted by the University of South Carolina Office of the Vice President for Research. Our presenters this evening are Dr. Melissa Nolan from the Arnold School of Public Health, Dr. Prakash Nagarkati, U of SC's Vice President for Research, and Dr. Helmut Albrecht from the U of SC School of Medicine and Prisma Health. We will begin tonight with a talk on the epidemiology of COVID-19 presented by Dr. Melissa Nolan.
Good evening. I would like to thank Dr. Nagarkati for the invitation. Tonight, I plan to discuss salient virology topics, define epidemiologic terminology you are likely reading and hearing about in the news, and close with some disease trends nationally, statewide, and within our campus population. Next slide, please. SARS-CoV-2 is a novel coronavirus that causes the infection known as COVID-19. This virus is a single-stranded RNA virus, which simply means its genetic material can serve as both a blueprint for making more viral copies and as messenger RNA, which can be made directly into protein. Coronaviruses are large, with a genome size roughly double that of influenza viruses. This virus can be pleomorphic, meaning that the shape can change, but generally appears spherical. The envelope and membrane proteins are instrumental in forming the outer shell, and the spike proteins allow for the virus to attach to human or animal cell receptors. We are already seeing genetic variation of this novel virus, with regional variants noted. That meaning, as new cases are diagnosed, we are seeing slight variances in the genetic makeup of the virus. These variances tend to aggregate by geographic location. A preliminary study suggests that type L appears to be more frequent and possibly more aggressive in its ability to affect new people. The clinical implications of these different genetic types are still unknown. Next slide, please. Coronaviruses as a family have 4 genera. The figure on the right is a phylogenetic tree which represents genetic similarity. Each virus is like a leaf on a tree, and leaves on the same branch are more genetically similar than leaves on different branches. Alpha and beta genera infect mammals, whereas gamma and delta genera primarily infect birds. SARS-CoV-2 belongs to the beta coronavirus genus and is genetically related to the original SARS virus from 2002. To date, 7 different coronaviruses are known to infect people, with 4 causing mild infection and 3 related to high mortality in large outbreaks. There are 33 coronaviruses that can infect a wide variety of animals with varying clinical presentations. Coronaviruses can have notable economic impacts on the farming industry, with outbreaks having been reported in poultry, swine, and bovine populations. Next slide, please. It should be noted that all 4 of the mild coronavirus types are regularly circulated in the United States. In fact, an estimated 15% of the common cold cases in the United States are due to coronaviruses. As seen in this figure from CDC, we see seasonal peaks of varying coronavirus types that fluctuate each October to April. These 4 types are known as 229E, NL63, OC43, and HKU. Clearly, we scientists need a better PR person to help us with naming our coronaviruses. Next slide, please. Zoonotic disease can be transmitted from animals to humans. Typically, these diseases naturally exist in animals and spill over into humans. Spillover in the context of zoonotic transmission relates to an unintended consequence. Examples of zoonotic spillover can be when people eat wild animal bushmeat, when they come in contact with wild animals during deforestation events, or have extensive animal contact due to farming or ranching. An amplifying host is one that produces a large number of viral copies, making it significantly more likely to transmit infection to others. In contrast, an intermediate or reservoir host can harbor infection without getting sick itself. Finally, indeterminate hosts are animals that can get infected but do not create enough viral copies to infect others. Okay, enough with the academic lesson. Back to COVID-19. Coronaviruses have a long history of co-evolving with bats and avian species. In regards to the original SARS virus, it was thought that in live animal markets, bats and palm civets closely lived in shared spaces, allowing for cross-species transmission and amplification of bat strains in civets. These civets then served as an intermediate host for viral evolution of the strain that eventually went on to infect humans. With MERS, camels served as an important intermediate host. With SARS-CoV-2, we are still trying to understand what animal is serving as the intermediate host. Next slide, please. SARS-CoV-2 has an affinity for pulmonary epithelial cells, which allows it to transmit via respiratory mechanisms. Dr. Nargacardi will detail the mechanistic pathway, but for now, I want to clarify how transmission of the virus occurs between people. Respiratory droplets are small drops of liquid released during everyday body functions and social interactions that are heavy enough to drop to the ground. In contrast, aerosolized droplets have a more specific definition, namely that they're small, around 5 to 10 microns in size, allowing them to stay in the air longer. SARS-CoV-2 has incorrectly been described as being airborne transmitted, which is an indirect route that does not require droplets. An example of airborne transmission would be dust that can be carried around by air currents. In closing, the average sneeze contains an estimated 1 trillion viruses that are circulated in a mixture of respiratory droplets and aerosolized droplets combined. Next slide, please. Respiratory transmission is the main way people are getting sick. However, as our pandemic continues, we're starting to understand other possible rare routes of transmission. In the United States, pregnant women account for approximately 2% of reported cases. We are still in our infancy of understanding whether mothers can pass infection to their babies while pregnant, during vaginal delivery, or through breast milk. Studies in South Carolina, New York, and California are ongoing to better understand the viral kinetics around the pre- and postpartum period. Next, studies dating back over a decade demonstrate that coronaviruses can be detected in fecal material. Oral fecal transmission can occur in animals. While SARS-CoV-2 virus particles have been detected in human feces, it is not believed that they are infectious. However, we believe that these virus particles could serve as an indicator of transmission in an area. Studies are working to understand how monitoring of wastewater virus particle levels could relate to the number of people that are infected in the area. Our very own Dr. Sean Norman is part of these important studies. Going back to respiratory transmission, fomites, or inanimate objects, can harbor infectious particles for several hours. Initial studies suggest that stainless steel and plastics can harbor infectious particles for hours or possibly days. While perfect laboratory conditions suggest that a doorknob could harbor SARS-CoV-2 for days, it should be noted that these studies also demonstrate that the transmission risk is highest within the first 8 hours. The take-home message: clean your frequently touched surfaces often. Next slide, please. For the first time in my career, people actually know how to say epidemiologist and that epidemiologists don't study skin. It's been a pleasant surprise that so many people know about the topics I learned about in school. I would be remiss, however, if I didn't include a slide with the correct definitions that we're all reading and seeing these days. First, a basic reproduction number is a complicated metric that can vary based on the given point that you are within a pandemic, the population that's being studied, and a variety of additional assumptions made. The take-home message is this: a basic reproduction number, sometimes called an R0, can tell you how infectious a pathogen is, or if you're in the upside or in the back end of a pandemic, and when expressed as a range, you can have a better feel for the pathogen's potential. Next, incubation period. This is the time in which someone is exposed until the time their symptoms start. The incubation period is one way we determine how long an exposed person should be in isolation to monitor if they develop symptoms. For SARS-CoV-2, the average symptomatic person begins to show signs of disease within 4 to 6 days after initial exposure, but it can be up to 2 weeks, which is why quarantine has been recommended for 2 weeks. An infectious dose is the amount of pathogen needed to establish an infection. An infection dose can vary from person to person and is likely related to underlying immunologic and genetic factors. We do not know what the infectious dose of SARS-CoV-2 is. We believe it is quite low, which explains why we see great disease spread. Viral load is the amount of virus in a sample. This information helps us understand how contagious saliva, blood, or other biologic samples are. Lastly, there are preliminary studies that suggest that high heat and high humidity can reduce the viability of the virus in the environment. One possible good outcome for our famously hot and humid Columbia summers. Next slide, please. Unlike influenza, we are starting to see that asymptomatic infected people play a very important role in transmitting this virus. Studies suggest there are no statistical differences in viral load between patients with severe disease versus mild disease, as indicated by the top left graph. There's no difference in viral load between healthy patients versus those with underlying healthy conditions, bottom left graph, and between those with symptoms versus no clinically apparent disease on the right. One theme we are seeing, however, is that viral load increases with age, as seen in the central graph, suggesting that older people might be shedding more virus, thus more likely to infect others than their younger counterparts. Next slide, please. Healthcare workers have always been known to be a high-risk group for transmission, given their increased close contact with infected people. What is unique about this pandemic is the expansion of additional occupational groups. There have been a few accounts of asymptomatic nursing home workers and asymptomatic prison officers that have introduced infections into institutions that have rapidly spread among these populations. And we are still learning just how many jobs and occupations require close contact that might be putting essential workers at risk. Next slide, please. Okay, switching gears, we're going to finish with some trends from the initial phase of this pandemic. Nationally, we have seen a flattening of the curve, as indicated from the CDC daily count of incident cases. To date, we have over 1 million reported cases, with 6% of these cases resulting in death. But as you can see, we're flattening that curve with less of a peak. Next slide, please. Similarly, in South Carolina, we are seeing a reduction and a hopeful continual downturn in cases, as indicated by this recent report from DHEC. This figure shows the incident case burdens by week since the beginning of local cases. Next slide, please. This figure from DHEC shows the percent of people who test positive out of all of those tested. This figure shows testing from the last 2 weeks. The take-home message from this figure is that we're seeing an expansion in our ability to test statewide and an overall decline in cases. Next slide, please. This graphic from DHEC refers to hospital surge capacity. A primary concern we had at the beginning of this pandemic was whether we would overwhelm our hospital resources and not be able to provide supportive care to all those in need. Thankfully, from this first phase of the pandemic, we have not reached peak capacity. Even at the height of peak cases, we used a fraction of our resources, giving great promise that statewide we have the resources needed to handle any future spikes in cases. Next slide, please. Lastly, we see that every county in our state has reported infections. As indicated by the darker blue shading, the majority of cases have been reported from metropolitan areas. So far, we have an estimated 4% case fatality rate that is lower than the national figure. Next slide, please. So bringing it back home, on our campus, we have had a small number of students, staff, and faculty reporting infections. Students, as demonstrated by the top blue line, represented the highest burden of infections. These cases peaked in late March, and we've had a minimal number of cases reported since campus was closed. Next slide, please. Infections among our campus body include students that live in different states, including a fifth of cases that reside in the northeastern United States. It is believed that half of infections among our campus body occurred in our state versus exposures that occurred following campus closure. And with that, I will pass the baton on to Dr. Nagakardi.
Thank you, Dr. Naga. That was an excellent talk. So, in my talk, so far you heard, where the virus originated and how the virus is spreading. So in my talk, if I can have the next slide, what I'll be discussing is, can I have the next slide? Yes. So I'll be discussing is how your immune response reacts to the coronavirus infection. And particularly, I want to share, the exciting concept that your immune system against the coronavirus is like a double-edged sword, that on one hand, you need the immune system to protect you from coronavirus infection. Almost 80% of the population can overcome this infection. But in about 10 to 20% of the patients who develop a severe form of this disease, it is actually the immune system that is responsible for causing damage to your lungs as well as other organs and cause, sometimes death as well. So therefore, I'm going to share with you the concept of immune system acting as a double-edged sword. If I can have the next slide, please. So when you inhale the virus, it gets into your respiratory tract, and the virus expresses what is called as the spike protein. And this spike protein binds to the host cells through a receptor called as ACE2. And ACE2 receptor is expressed extensively throughout the body, and particularly into your respiratory tract. And so that the virus is using the spike protein as a key to open the lock so that it can get into the cells. Once it gets into the cells, it can replicate rapidly and can further spread the infection, right? So what does your body do that time is that it produces B lymphocytes it triggers the B lymphocytes to produce what are called as antibodies. So antibodies are molecules that can bind to, for example, the spike protein and prevent that protein from binding to ACE2. In other words, the antibodies can block the key so that it cannot open the lock anymore. Now, our immune system produces a variety of antibodies directed against so many different molecules expressed by the virus. But the most important antibody is called as the neutralizing antibody. So this is an antibody that specifically binds to the spike protein so that it cannot enter the cells. So therefore, immunologists, when we are trying to look for vaccines, we want to make sure that the vaccines trigger these neutralizing antibodies. So in this slide basically shows that if you produce an optimum immune response, it can clear the infection and therefore you're going to recover fine. In the next slide, I also wanted to show you that in addition to the antibody molecules, our immune cells also produce other protein molecules, what are called as cytokines. And these cytokines, when they're produced in small quantities, they can get rid of the viral infection, they can bring other immune cells to the site. So basically, they are the ones which, make you get fever and, you get inflammation, and that is because of these cytokines that are produced by your immune system. The lower panel shows what happens when a patient is immunocompromised. That means, a patient may be elderly or has certain other comorbidities. And if your immune system is not functioning and you're not producing enough neutralizing antibodies initially when you're infected, then what can happen is your infection can keep spreading into the lower part of your respiratory tract. Next slide. Can I have the next slide, please? Okay, so it's important to remember that while the virus enters your respiratory system and acts through the ACE2 receptor, enters through ACE2 receptor, the ACE2 receptor is also expressed on other immune cells as well as other types of cells. So it's been shown that ACE2 receptor is expressed in the brain, in the heart, in the kidneys, the GI tract. All the blood vessels, the endothelial cells that line the blood vessels also express the ACE2 receptor. Now, you have heard a lot about the antibody molecules, but you've not heard about another type of immune cell, what is called as the killer T cell. So the killer T cells also play as important a role as the antibody molecule. And what these killer T cells, immune cells, do is that they can sense when a normal cell gets infected with the virus. So as soon as the cell gets infected with the virus, the killer cells get a signal and they kill that infected cell before the virus has an opportunity to divide and multiply. So therefore, the killer T cells are also important. Having said that, these cells kill the cells that express ACE2, then you can imagine as the infection spreads, the killer T cells are also going to cause damage to your heart, your kidney, other organs, brain, and so on and so forth, and you suffer from the clinical symptoms that are associated with these killer T cells destroying your own cells. Next slide, please. So in addition to that, what is happening now in the lungs is that your lung has what is called as the microbiota. It has got millions of these bacteria and viruses that live in harmony normally. But when there is an active viral infection and when there is severe inflammation that is going on, then what happens is the microbiota get disturbed, and that leads to the pathogenic microbiota or pathogenic bacteria and viruses taking a dominant role and start causing more of infections. So at that time, what happens is the immune system gets worried and it says, oh my gosh, there is not only this viral infection, now the bacterial infection, other things are going on. So it goes into full gear and starts producing tremendous amount of cytokines that attract other immune cells to the site. So it leads to a condition, clinicians call it as a cytokine storm. And that combined with the killer T cells, what happens is the immune cells start releasing these toxic chemicals to kill the virally infected cells or kill the virus. At the same time, what is happening is there is friendly fire. That means significant damage caused to your alveoli and the lungs. So therefore, the oxygen levels drop, and you can have loss of blood pressure and so many other things that are associated with the cytokine storm. So this also can lead then to multi-organ failure. And once you have all this, it's difficult to kind of save the patients. Next slide, please. So let's move on to some of the tests that are used for diagnosis of the COVID-19. The first test, which is very popular, is called as the nucleic acid test. So what it does is you take a swab, nasal or the oral swab, and you can then use what is called as the RT-PCR reaction. What it does is it can help detect even a single virus particle because it's so sensitive that the virus particle RNA gets amplified and you can detect that. Now, interestingly, many of you may not have known this, that the PCR reaction, the polymerase chain reaction, PCR reaction, was discovered by Dr. Mullis, who is a Nobel laureate. And I'm sure you didn't know that he studied in Columbia. He went to Dreher High School, and unfortunately last year he passed away. But it's so exciting to see, the entire globe is using the PCR reaction to detect this infection. And this was contributed by Dr. Mullis from Columbia, South Carolina. So that is pretty exciting. So now the advantages of this test is that it's highly sensitive. As I said, even one virus particle it can detect. But the problem is that it needs special equipment, like I have shown you there. It needs special reagents and it takes a long time. And what the test does is basically it can help isolate the patients. And it's important to remember, like Dr. Nolan said, that sometimes the patients can be symptomless but still shedding the virus. And so therefore, you can detect using this particular nucleic acid test. Next slide, please. So this is another test, what is called as the antigen test. And what it does is basically, it does not detect the RNA or the nucleic acid, but it detects the other antigens or molecules expressed on this virus particle. So it can, for example, it can detect the spike antigen. So this assay is very simple. and it can be as simple as like a pregnancy test. And what you can do is you can take a swab and put it on a strip, and based on the change in the color or positive or negative, it can tell you that. So that's the advantage. But the disadvantage, it's not very sensitive. Mostly, like 80% of the time, a person who is really infected shows up as positive. But the advantage is that everybody can, even down the road, everybody will be able to do it even at home by yourself if it's possible. Next slide shows you what I call as the antibody test. So these are tests that measure the amount of immune response that is triggered by inside the patient, right? So there are two types of tests. One can detect the IgM that is produced early on, or detect the IgG antibodies, which it takes at least 2 weeks sometimes to develop these antibodies. Now there are 12 approved tests by FDA, but there are over 100 non-approved tests. And that is because they wanted to make sure that they release all of these tests so that people can get benefit out of that. But the feedback has been that a lot of these tests, which are not approved by FDA, might give you high false positive or high false negative responses. So you must be careful when you try to use the antibody test that it be approved by FDA. Also, the drawback of this compared to the previous two tests where you take the swab is that you need to draw blood here. And you can, of course, use a lab test, like what is called as the ELISA test, or you can use a strip as well to find out whether you're antibody positive. It helps also to know whether you are currently infected or you were infected, because even if you cleared the virus, you'll still have the antibodies, because the IgG antibodies can be there without any problem for several months. So you can detect the antibody levels for up to several months. There is also a question about whether, once you're infected, whether you become immune or not. So against most viruses, I think that you'll have immunity at least for a year, because that's how long the antibodies like IgG will survive in your system. But sometimes, these antibodies can disappear much faster, or sometimes they can live for couple of years or even sometimes several years. So now this also antibody test helps survey how many people are infected and what is the reinfection rate. And some saying that maybe this can be used as a certificate to join workforce, because you already contracted the disease, you have overcome the disease, now you are immune to that. This test also can be used to find out, before you do the plasma transfers, you can check whether that person has the antibodies, but we don't know which of these tests would detect neutralizing antibodies, because those are the ones which are very important. And then you heard about herd immunity, that is the immunity across the population, right? So because this is a new virus, we don't have any immune response against this. We don't have any immune response. So all of us to begin with are at a baseline, and we don't have any immunity against this virus. So the way that we can spread herd immunity, that everybody has some level of immunity, is by either promoting infection or by vaccination. Promoting infection we cannot do, because even if it kills 1% of the population, that is almost 3.3 million people in the United States, right? So we can't do that. And vaccines, of course, you are waiting, right? Till then, there are some countries like Sweden, for example, might want to encourage the younger generation to go and work and contract the disease, but because they get mild disease, they overcome the infection, and that's another way to spread herd immunity. But you have to make sure that the vulnerable people are sequestered and they're isolated. Otherwise, that could be tragic as well. And we need to find out, of course, like how long the immunity will last. Next slide, please. So this is a graph that I've taken from the WHO, which shows you first in the blue line when you can detect the virus. Starting with day 1, you can start detecting the virus up to about 2 weeks. And then as you start producing, the green one is the IgM antibodies. You start producing after 1 week of infection. It peaks around day 14 and then it drops by day 21. So as the IgM antibodies are being produced, the virus levels also start decreasing. As the IgM levels start decreasing, the immune response starts what is called as the secondary immune response, where it starts producing these IgG antibodies on around day 14, and they can last for a longer time. And also our vertebrate immune system is made in such a way that we develop what is called as memory response upon our primary infection. So if you come across the same infection second time, our immune system is going to mount a very strong and vigorous reaction so that the virus or the bacteria can be cleared. So that's what is called the memory response, because of which the vaccines work. So this chart is very critical because, for example, if you are using antibody tests to detect IgG and you start doing it within 1 week or even up to 7 to 14 days, you might find that it's coming negative, and you may have to wait till such time, that the person shows positive. So there are a lot of issues to interpret the test results. You need to be familiar with this particular chart overall. Next slide, please. So about vaccination, don't have the time to go through all of this. There are over 100 vaccines being right now being developed. The important thing is that these vaccines should be able to trigger the neutralizing antibodies as well as the cytotoxic T cells. So therefore, some sort of an attenuated live virus would be great. I have a strong feeling that the vaccine is going to be highly successful, and that is because we know that this virus triggers a very strong immune response. The question is, of course, will the virus mutate to an extent that the vaccines might fail? Most of the evidence shows right now that this virus does not mutate as much as some of the other viruses. And the question is, why does it take so long time to develop the vaccine? Actually, the development of the vaccine doesn't take much time, but it is based on how long it takes to do the clinical trials, because some vaccines, instead of triggering neutralizing antibodies, they trigger what are called as enhancing antibodies, which bind to the virus, in fact, facilitate infection, or might trigger a very strong inflammation, because of which, we want to make sure that the vaccine can be tested in individuals to make sure that it's safe. So that takes a lot of time, and then, of course, to make millions and millions of doses of the virus. Next slide, please. Yet another approach, which is a different approach, is to identify the neutralizing antibody, try to know its structure, and clone it and produce the same antibody by culturing them using what is called as growing the single cells. Now you can produce tons of these antibodies that can be transferred back into the patients. And because we know that these antibodies are directed all against the spike antigen, we are 100% sure that it is going to be effective. So that's being tried out as well, and we'll see how successful this approach is going to be as well. Next slide, please. So this is my last slide. So basically what I wanted to convey is that you need an immune response to get rid of the infection, and that's what happens in 80 to 90% of the population. They develop the optimum immune response and they can clear the infection. But in 10 to 20% of the population, what happens is, because they don't have an initial good immune response, the infection spreads, and that triggers other infections or cytokine storm by the immune response, and that causes acute respiratory distress syndrome, multi-organ failure, and so on. So in order to boost the immune response, there are not many agents which can boost your immune response, and there is some speculation about trying out BCG and polio vaccines, for example. But importantly, to prevent the cytokine storm, to prevent multi-organ failure, you need to have very potent immunosuppressive drugs that can block these cytokines. And there are some clinical trials being done in that area as well. So that's why I just want to conclude my talk by saying, the immune response against coronavirus, novel coronavirus, is like a double-edged sword. On one hand, it is helpful, it is absolutely critical, but in patients who are dying, this may be detrimental as well. So now I'll pass on to Dr. Albrecht to talk about, what are some of the clinical and treatments available for COVID-19. Thank you.
Thank you, Dr. So I'm the cleanup hitter, and we'll take you through the symptoms, the course of the disease, and the therapy of COVID-19. Next slide, please. Next slide. Most of you can probably list a couple of the typical symptoms, and in patients we see in the hospital, we usually see a combination of cough, shortness of breath, and fever, actually which each one of these being present in over 75% of patients admitted to our hospital. CDC has recently added 6 more symptoms, but there are really dozens of other presentations, and none of these are very specific, with probably the exception of a peculiar loss of sense and smell, which can happen with other viruses too, but it appears much more common to be with this virus. In the outpatient setting, on the other hand, and you heard that now twice before, we see a lot more asymptomatic patients, or if they have symptoms, they may have atypical symptoms such as back pain or fatigue or nausea. All in all, symptoms that usually do not result in getting you tested here in the US. Next slide, please. These are some of the studies that show that some investigators found very high percentages of asymptomatic patients. Some serosurveys using the antibody tests that Dr. Nagakari mentioned seem to suggest that we miss a vast majority of patients if you only test patients with symptoms. Next slide. The typical course of disease has an incubation period that Dr. Nolan mentioned, so the time from infection to first symptoms of around 5 days. But it often takes another week before patients come in and get tested, either because they're getting worse or not any better. This means if you look at statistics of new cases, you're looking at a scenario that actually played out 10 to 14 days ago. We already talked about asymptomatic patients, and it's becoming clear that patients can shed the virus or start being infectious a couple days before and a couple days after their symptoms have resolved. Next slide, please. The typical disease is a pneumonia, often in both lungs, which is what we call bilateral pneumonia. Left is a normal chest X-ray with the heart in the middle and the grayish lungs on each side, with the ribs showing through and the diaphragm below. In the middle, some of the gray is taken over by white infiltrates, which is the COVID pneumonia. And on the right side, the disease is so far advanced that it's hard to see the heart, the diaphragm, or the ribs. Next slide, please. On a CT scan, we see a fairly typical pattern. The green marks there, or for the colorblind, what is marked with a green square is normal lung, and the red circles show all the areas of infected lung, with most patients having several areas of pneumonia, not only one. Next slide, please. When more organs become infected or affected, when patients progress, the prognosis gets worse. Dr. Nagakari already talked about the hyperinflammation, or the so-called cytokine storm, which often results in the shutting down of multiple organs. Advanced cases, the heart can be involved, as can be the brain or the nervous system. In several of our patients, we've seen somewhat atypical clotting problems, leading to heart attacks, pulmonary embolism, or thrombosis, which are not fully understood yet. But the presence of any of these is prognostically bad, and certainly associated with a higher risk of death. Next slide, please. Death rate is itself, it's very dependent on where the patients are that you're analyzing. In the ICU, mortality can be quite high, especially if patients are on ventilators. But it looks much less threatening if you include patients who have no or little symptoms. You also heard that mortality is age dependent and often affects persons with other clinical illnesses. Next slide. So this is a slide that compares the mortality in COVID on the right with the flu on the left. I've actually used data from South Korea, as they've done a very good job in testing patients. While a couple people have pointed out how influenza and COVID share some similarities, and they do, they're probably more different than similar. In both illnesses, indeed, most of the mortality is in patients with advanced age. You do see, however, COVID mortality is much, much higher, and the age range of deaths is much more spread out. Next slide. This is a situation in South Carolina, and Dr. Nolan has shown you the numbers, but here in the bar graph in the lower middle, you see that our situation when it comes to deaths is very similar, with a majority of deaths in patients over 65. But you can also see that almost 10% of deaths are seen in people in their 50s. And furthermore, while deaths in younger people are still quite rare, they still occur. The one patient listed here in the 30 to 40 year bracket, for instance, was a student of ours from USC Aiken, and every one of those losses is a real tragedy. In the upper left large circle, you see that most infections are actually diagnosed in women. However, if you look at the smaller left circle on the left, you see that men were much more likely to die. This could be because men tend to seek health care later, but it may be due to hormonal or genetic factors that actually increase or decrease your risk of dying. At any rate, after man flu, man cold, now there's also man COVID, and it looks like it's real. On the upper right, you can see that there's also racial disparity, with African Americans making up 27% of our population, but account for 36% of the cases, and even more disturbingly, 57% of our deaths. There are certainly societal and socioeconomic factors that you can blame for this, but there are probably also genetic issues that can explain some of this. Next slide. Going on to treatment, I will only have time to cover 4 of the several hundred different treatment approaches, next slide, that are currently being studied. I'll start with remdesivir, next slide. Remdesivir is a very broad antiviral. It was actually developed as an Ebola drug, but it also has activity against coronaviruses. There have been a couple studies now. They've been put together fairly hastily, but we have participated and had a chance to be on board very early in several of them. Got to treat several patients with this drug and have gathered some experience with this in the process and understand it now much better. Not all of these studies actually have shown a success. The first study in China and the second study comparing a high dose versus a low dose study showed no real difference. Decidedly better study that was very recently released in early data cuts that compared standard of care with standard of care plus remdesivir finally showed an improvement with remdesivir. On average, it took patients 11 days to improve on remdesivir versus 15 days if they did not get it. There was also a trend to lower death rate with 8% versus 11.6% on remdesivir. Next slide, please. So in my personal opinion, I think this will actually prove effective, but the effect will be somewhat limited and will probably work better in patients with less advanced disease than what we're currently testing it in. It has been now approved under a emergency authorization, and it will be distributed by the feds. And nobody really has a good idea how we will get access to this drug. There is a federal website, and we have certainly asked to be included in this, but currently there's nobody from South Carolina on this website. And we hope that they will not all go to New York, but you never know. The good news is we're still participating in the studies that only a few institutions have access to, and we will at least have some guaranteed access to the drug that way. Next slide. Next are biologics. Next slide. These are actually drugs that you see on TV every night as the newest treatment for moderate to severe plaque psoriasis or rheumatoid arthritis or something alike. There are dozens of these, and they tend to work by shutting down various parts of the immune system, and all of them are being studied in one way or the other with the hope that one of them or more of them will be able to rein in the hyperactive immune response that threatens patients with COVID-19. Most well known is probably tocilizumab, and like everybody else, we tried this as well, and I'm going to show you very briefly our early experience that Dr. Weissman and Justo put together. It's only 19 patients, but that's actually nowadays a pretty decent sample size. Next slide. As you can tell, in our hands, this didn't work so well, with more than 40% of patients dying and another 20% having to transition to hospice care. Next slide. Part of the problem is that as monotherapy, these are probably too little, too late, and this will not work with any on either of them, I think, alone. While they're also quite expensive, they also might be dangerous as they shut down parts of the immune system, which is how they work. But that it's difficult to tell which part of the immune system you can and which part you actually shouldn't shut down. At any rate, the immune system is a very complex apparatus, and going into this with these meds, to me, always feels like we're going into a Swiss watch with a hammer. Very blunt instrument. May work, but usually it doesn't. Clearly need better approaches like earlier therapy, but we do not have markers to tell us who would benefit, or we need to combine modalities, like for instance, in the next slide, a new study in the upstate. So this study is planned to combine plasmapheresis, which means removing some of these inflammatory substances with one of these biologics that will suppress making them anew. And while we have started enrollment, it's too early to tell if this works. Next slide, please. Chloroquine and hydroxychloroquine, everybody has heard of that now. Let me tell you, they're very misunderstood and very overrated. Next slide. They are actually a very different drug, which is the first thing that people need to understand. Chloroquine is indeed an antimalarial, but hydroxychloroquine is not at all. And that's what 90% of people actually got. It actually suppresses the immune system, may therefore be a particularly poor choice in early infection or even in prevention. Both, however, affect how zinc goes into the cell, which may actually affect viruses, but they are not antivirals by itself. They certainly had some theoretical promise, but next slide, they really didn't seem to do anything in our hands. Study by researchers from the University of Virginia and USC, here Dr. Harden and Dr. Scott Sutton from the School of Public Health and School of Pharmacy at USC pointed out, put the final nail into the coffin. Not only that these drugs did not help, but patients who were on hydroxychloroquine were 2.5 times more likely to die as when they didn't get it. And it's probably easy to see why we're therefore hardly used those anymore. After that depressing news, next slide. Here's actually a more uplifting story, which is convalescent plasma. Next slide, please. Convalescent plasma already mentioned transfusing antibody-rich blood plasma from patients who have recovered to patients with acute and severe disease. This is organized by the FDA in the national study led by Mayo Clinics. They opened this up on Easter, expected 20 patients, got 2,000 registered on just the first weekend. But we already were at a point where we plan to do our own study, and we're pretty advanced. We therefore got a pretty early start with this and opened this up here locally on the first day. Next slide. We're actually the first to give convalescent plasma in South Carolina, first to recruit donors, first to organize a plasma drive, and actually today the USC Student Health Center became a collection site for convalescent plasma for recovered patients. So we're doing a lot of things on a different fronts. We've now transfused over 25 patients, but I won't show you any data of that, but actually we'll show you a letter. Next slide. This is the first patient who got transfused. Wrote a letter to Dr. Rayner, who is the medical director of the Blood Connection, and me. And she was the first patient in South Carolina, as I've said. She's also a nurse at Prisma Health Richland, and got hospitalized on Friday before Easter on 4/10, and was found to have bilateral pneumonia, very high fever, and was quickly getting more ill. She was about to get intubated and put on a ventilator as she was tiring out when we found her some matching plasma. Next slide. Actually, she tolerated this pretty well, and while I'm running over, so you will have to read this later, but interestingly enough, not only that she slept and we were able to get her off oxygen in a day, actually her sense of smell and taste that usually takes patients weeks to recover, she got back the next day, and she actually went home on the next day. Next slide. And next slide after that, and skip one further. One more. Yes, thank you. Critical. So no, one back, please. So I want to make a short statement about symptomatic therapy, not very sexy and undervalued, but so important. These patients can have no visitors. They only have healthcare workers at their bedside. And our mental health and palliative care providers and the nurses have done a great job to get our patients through this. It's also really important to have good critical care docs that understand this. It's even better when you have great critical care docs like we have. They figured this out fairly quickly, and why some hospitals in New York and Italy have lost up to 80% of their patients on ventilators, most of our intubated patients are actually leaving the unit alive. Their mortality is relatively low. Last slide, please. Here's actually the summary of our strategy. It looks complicated, but we're getting the hang of this. In phase 1, the virus dominates and you want to strengthen the immune system and fight the virus. In phase 2, you need to battle the pneumonia. And in phase 3, when the cytokine storm takes over, you need to rein in the inflammation. Easier said than done. We do not have perfect tools for this, but we are making progress and are actually getting better at this. Thank you. That was my presentation.
Elizabeth, unmute your mic, please.
Got it. We will now take questions from the audience for about 15 minutes. Our first question is from an anonymous USC staff member. What kind of mask gives the best protection? Dr. Nolan, will you address this question, please?
I love that question, but I'm actually going to punt it over to Helmut because we've had several conversations about this, so I can finish up anything that he might have missed.
So it's very easy to answer. It depends. So all of us wear masks all day. We have universal masking in the hospital, which means we're handing out 30,000 masks. We're not getting masks to all of our providers to protect ourselves. We're actually wearing masks to protect people that are around us, patients, co-workers, visitors. So for that, you can use almost anything that keeps your secretion next to you. If I go into a room, I just need a barrier. I actually use a surgical mask when I go into the room. When we are doing procedures that require or have the risk of aerosolization that Dr. Nolan talked about, we use N95 masks. So there's an optimal mask for every condition.
Excellent. Thank you, Dr. Albrecht. Our next question is from Wendy, a graduate student. Why do people who are obese, diabetic, or have high blood pressure seem to be at higher risk for COVID? And is this true? Dr. Nagarkati, what do you have to say about that?
Doctor, please unmute your mic.
Sorry. So this is a great question. So as an immunologist, I feel like inflammation is the underlying cause of a variety of diseases, such as obesity, hypertension, certain diabetes type 1, so many autoimmune diseases. So there are a lot of diseases, even cardiovascular disease and neurodegenerative disease. So there are a lot of diseases in which there is chronic inflammation that's going on. So it is likely that that might further be enhanced by the viral infection as I described. But I would also like to have some feedback, clinical feedback, I think, from Dr. Albrecht to see why that comorbidity is there. Helmut?
Well, I think you correctly pointed out that the missing link is probably inflammation. The other thing is that a lot of these diseases affect the organs most important for this, which are the lungs and the heart. So if those organs are chronically affected, you will have less reserve to deal with this disease. Thank you.
Thank you very much. Our next question comes from Dr. Susan Wood, a faculty member at USC. For those of us who were in direct contact with a known COVID positive patient, is there any internal option to get tested for antibodies so that we can donate plasma? Dr. Albrecht, why don't you take that one?
So could you give me that question again? Sorry.
Certainly. For those of us who were in direct contact with a known COVID positive patient, is there any internal option to get tested for antibodies so that we can donate plasma?
Yes, and actually on Friday, the protocol from the Mayo Clinic started including patients who only tested antibody positive, never had a confirmatory test. So that is possible now. Prisma Health, for instance, is offering this antibody test, and every provider can offer that. And in our research unit, we have 2,000 additional tests that we're going to be using partially to qualify donors for plasma donation. Thank you.
Excellent. Thank you, Dr. Albrecht. Our next question comes from Regina, a USC staffer. When we begin to return to campus, should we wear masks when we're on campus? Dr. Nolan, why don't you take that one?
Yeah, thank you, Regina. That's an excellent question, and one that us as the Future Planning Group have been discussing. We're hoping that there will be some guidelines that will be coming out to describe this, but I would say will likely be in accordance with what we're seeing with national and state guidelines. And at the current moment, they are recommending that you have some type of face protection. And to kind of just go off of what Helmut said before, when we talk about wearing just a general face covering, that's really not necessarily to prevent you from getting infected from others. It's for you to protect others, so that if you are an asymptomatic carrier, you can help create a physical barrier from spreading this disease to others. And then of course there's another level, which would be surgical mask. And that would be really if you're coming in more close contact with people. So I would envision that it could be, we might require you to have some type of face protection, the level of which we're still deciding. But again, I would say future guidelines on that will be coming out. But at the end of the day, absolutely our most important priority is to protect the safety, health, and well-being of all of our campus populations, whether that be staff, faculty, or students. Thank you for the question.
Thank you, Dr. Nolan. Our next question is from Muthana Sultan, and the question is, it has been recently found that skin lesions, specifically around fingers and feet, in about 30% of COVID-19 patients. In this situation, does that put people with skin allergy at a higher risk of infection? Dr. Nagarkati, why don't you start this one?
I will I will turn it over to Dr. Albrecht, I think.
Yeah, I figured you would do that. So the skin lesions are actually very interesting and very diverse, and they have very different reasons why patients such as this have skin lesions. So one of the types of skin lesions is a sort of allergic reaction to the virus, but some of them are related to the blood clotting events. And so the virus does not get absorbed through the skin, not even through broken skin and unhealthy skin. If you have multiple skin allergies, you have a different immune system as well. So this does set you up for different kind of events, but probably doesn't make you a lot more susceptible to this. So the answer would be, I don't think so. This would not make you a high-risk patient.
Thank you, Dr. Albrecht. We've got 2 more questions to go from the audience. The next question is from a community member named Ed. Is there sufficient empirical evidence to suggest what secondary waves might occur or what mitigating strategies might need to be deployed in the future? Dr. Nolan, why don't you take this question, please?
First off, I'll say, Ed, thank you so much for tuning in. It's really exciting for us to get to talk to the public and, expand beyond. We recognize that the University of South Carolina is an urban campus and that we are all in this together as one large community. In response to your question, I would say that we are very closely monitoring the efficacy of social distancing guidelines and trying to see what's working and what's not. And I can assure you that moving forward, we're going to do everything we can. I think our ultimate goal is to make sure that as we see cases in the fall, that they're going to be more periodic, kind of isolated cases, and the goal is to reduce the potential for it to be a continued sustained peak transmission. Thank you for the question.
Thank you, Dr. Nolan. And our last question for the evening comes from another community member named Neil. Neil asks, I live in Columbia. Is it true that long-term quarantine, such as we have been going through, can weaken our immune system overall? Dr. Nagarkati, this question's for you.
Oh, I couldn't hear that properly. Can you repeat that again?
Certainly. Neil lives here in Columbia, and he's wondering if it's true that long-term quarantines, like we're going through right now, can be weakening to our immune systems overall.
Yeah, Neil, that's a great question. So I think the way we are staying at home for, like a couple of months or whatever, I don't think that impacts your immune response, even if it's whatever it's long term or short term, as long as, we make sure that we don't get stressed out, because stress has clearly been shown to suppress your immune response by inducing, for example, corticosteroids and all that. So as long as you eat well and, sleep well and do exercise and don't get stressed out and, go for walks or whatever, I think your immune system should be fine. It's only if this goes on for a very long period of time where, like say if you're imprisoned in a cell for years, and then, then what will happen is there is less possibility that you have been getting more exposed to different types of pathogens. And so that time you might become more susceptible. But I don't think this sequestration, the way they're doing right now for a couple of weeks or few weeks, is going to impact your immune response, whether it's short term or long term. Thank you for that question.
Thank you very much, Dr. Nagarkati. And thank you to our audience for joining us this evening for the Understanding COVID-19 Virtual Town Hall. Have a nice evening.